Croeso I sesiwn dysgu dros ginio yn gyrhaile gan raglen gwasanaethau a mysodiadau Rywol Cymru. As you can tell, I'm not a native Welsh speaker, so welcome everybody and afternoon. I'm echoing. Would everyone mind putting their mics on mute, please? Thank you. So welcome everybody to the Welsh Sexual Assault Services Programme Lunch and Learn session that's going to be taken by Dr. Helen Monroe today on emergency contraception, sexual infections and post-exposure prophylaxis after a sexual assault. Before I hand you over to Helen, I just want to do some general housekeeping rules. So I'm not sure if you've seen in the chat that this session is going to be recorded and then shared on our webpage. Please can you turn off your cameras and microphones, and the chat box will be open for any questions and comments that can be responded to either during or after the session. So thank you all, and I will pass you over to Helen.
Thanks, Jo. Okay, this is where I tried to share my screen. Can you see that, Katrin?
Yeah, we can see it.
Yeah, is it one slide or is it multiple slides?
Just the one.
Just the one. Fantastic. I got it right this time. So thanks very much, Jo. And yeah, so my name is Helen Monroe. I'm a consultant in sexual and reproductive healthcare. Before moving to Wales, which has now been 6 years, I was involved as a forensic medical examiner in London, and I worked for the Havens and part of the team there, so in Paddington. And so my disclaimer is that I haven't been involved with acute forensic examinations for a while, but this is what we call a lunch and a learn session. And so I'm pleased to see that we've got some very expert colleagues on the call this lunchtime, including my colleague Katrin Simpson, who's the head of our sexual assault services for paediatrics in Cardiff. So do put questions on the chat. And if you have answers for those questions, even better. And let's take this opportunity to learn a little bit more about each of the services and to understand a bit more about the acute provision of emergency contraception, PEP, and sexual infections. So I shall just scroll to the next slide. So what will we cover? So what is expected in the acute presentation? What does the Faculty of Forensic and Legal Medicine state around that initial presentation of a victim to a sexual assault referral centre, and how can we best support and screen people for emergency contraception needs, post-exposure prophylaxis, sexually transmitted infections? And I won't keep you for the full hour, so don't worry. So this is what the Faculty of Forensic and Legal Medicine state around what should be done at that acute presentation. So if we think that the FFLM are obviously putting together the key recommendations and medical legal guidelines, then if you go to this document that I've highlighted on your screen, you'll see this statement on one of the pages, and it's arrange appropriate treatment referral, including for emergency contraception, post-exposure prophylaxis, and screening for sexual infections. And I'm very aware that across Wales, we have different provision of these three entities in our sexual assault referral centres. And we're obviously working as a programme board with our local providers, both the FMEs and our third sector organisations, to ensure that actually whatever centre a victim attends, they're going to get the same provision of these three elements, whether it's emergency contraception, PEP or STI screening. So we are working towards that. And in the meantime, I think depending on where you're working, just make sure you have a good relationship with your local sexual health consultants and contraception clinics and GPs, obviously, to know where people can access these elements if you do need to refer on. So really important to build those relationships locally. But we are going to look at the first one, thinking about emergency contraception. So if you're not aware, the Faculty of Sexual and Reproductive Healthcare, which are the main provider of guidelines around contraception for delivery in the UK, with about 14,500 members, do come up with some very robust guidance on a regular basis, which the majority of it is free to access to anybody, a healthcare professional or member of the public. And in 2017, and then amended in 2020, we published a guideline around emergency contraception. And the key question is obviously who should have emergency contraception, and particularly in the situation where we're thinking of today in an acute presentation following serious sexual assault. So any female who obviously is not on ongoing contraception, particularly who isn't using a LARC method, that's the long-acting reversible contraception methods, such as an implant or an intrauterine device that are over 99% effective, should be offered emergency contraception. Or perhaps a woman who is using a method of contraception, but perhaps a pill, where they may have forgotten to take some pills or not taking it regularly, then they should also be offered emergency contraception. And I would suggest that if you are looking for some further help about, if you're a GP or you're looking for some more advice and support, then the Faculty of Sexual and Reproductive Health do regular courses on basics in contraception care, and these are available online and can be done face to face. So it's important that if you are delivering acute service as a forensic medical examiner or as somebody working in a SARC centre, that you have a good understanding about when somebody should be having emergency contraception, and also about what is the availability of it locally if you need to signpost. This is another really good tool that the faculty have come up with, and this is around what types of emergency contraception can be delivered when. And this is particularly useful if you're worried that they're particularly high risk or mid-cycle, for example, and you're thinking about what the potential options are. And so using an algorithm like this, if it's middle of the night or early morning, when perhaps you're not thinking so straight, it can be quite useful just to work through the potential options. But of course, the majority of women who perhaps come to a sexual assault referral centre, you may have in your premises one of the hormonal pills. And we have two pills now available to us, and this is ulipristal acetate and levonorgestrel. And up until probably the last decade, we really only had levonorgestrel tablets, the 1.5 milligram. We now have ulipristal acetate, also known as Ella-1, and this can be bought over the counter as well, just to make you aware. And we know that Ella-1 is much more effective than levonorgestrel at preventing an unplanned pregnancy. So ulipristal acetate, 30 milligrams, can be given up to 120 hours after an episode of unprotected sex. So it can be obviously used much later if somebody presents later on after a sexual assault than levonorgestrel, which is only licensed up to the 72 hours. And we also know when it comes to preventing pregnancy, Ella-1 is more effective because it can be used just before ovulation, so just before that LH surge, where levonorgestrel cannot. So there are definitely some benefits to you ensuring that you have Ella-1 in your cupboards if you are seeing women in that acute presentation, because it's probably going to be more effective than levonorgestrel in most cases. Obviously, there are some caveats which we need to be aware of. So Ella-1 shouldn't be used in people who have severe asthma, or those who are using enzyme inducers, or perhaps have used a recent contraception pill, for example, that contains progesterone. And the other thing is in pregnant women as well. So it's not recommended that you take Ella-1 and breastfeed for at least 7 days after. So that's something to be aware of if you do see women who are breastfeeding. Levonorgestrel, as we've said, is licensed up to the 72 hours, has no effect at the point of ovulation or just before ovulation. And in women who have a BMI of greater than 26, which also a weight of 70 kilograms or more, then you should be doubling the dose. So some key things to think about when you are seeing women who are presenting and you've screened them and you're looking to give emergency contraception. But let's not forget the copper IUD. And I think we can sometimes have a bit of a mental stumbling block thinking about inserting a copper IUD after a sexual assault because of the idea that somebody's gone through such a horrific experience. The last thing they're going to want is having an IUD fitted. But it is the most effective method of preventing pregnancy. And you do have longer in order to be able to give it potentially. So remember, the two rules for inserting a copper IUD is up to 5 days after an episode of sex, or up to 5 days after the earliest time of ovulation. So this is where it's important that you know where your local contraception clinics are that can fit an IUD, and that you signpost appropriately. Because although the person might not want to have it fitted there and then at the time that they're seeing you in a SARC clinic, they may actually, once they're home or a couple of days later, decide that they do want to have that copper IUD fitted, and it's important that they know where they can access that. If that is the situation, please still give Ella1 or levonorgestrel when you see them in the clinic, because they may change their minds or they may not get to the clinic afterwards for their IUD. So you can still give Ella1 or levonorgestrel, and then obviously signpost them appropriately to have an IUD fitted. So when it comes to obviously advice and follow-up, it's important that you remind the person that no method of emergency contraception is 100% guaranteed. And so they have to know where they can go in terms of getting a follow-up pregnancy test. And some people give that away with them so that they can do that in 3 weeks' time. Or obviously they can go to a local sexual health clinic or their GP practice. Ulipristal acetate and levonorgestrel can be given multiple times in a cycle. So if you risk assess a person in your clinic and they've already had emergency contraception in their cycle, depending when it was and what type it was, you can repeat it. So that's an update on certainly previous guidance. Provide written information about the type of emergency contraception that's been given, that pregnancy risk, obviously, if further unprotected sex occurs, and the possible side effects, particularly around bleeding. Emergency contraception can bring on bleeding and spotting, and sometimes that can be misconceived or misinterpreted as a period, and sometimes it can just be an implantation bleed. So it's really important that somebody does that follow-up pregnancy test at 3 weeks. As we've said, do talk about the copper IUD, even if that's not something that person wants at the time, because there often is a longer window period in which they can access it, and they need to know where they can go to get that done.
Alan?
Yes.
Sorry, just before you move on, just because there's a question that's pinged up in the chat that might be relevant. So it's just a question to say, are the indications and contraindications for contraception methods exactly the same for post-pubertal younger girls?
So well, I'm glad they've brought that one up, Catherine, because you're here. So in terms of contraception for post-pubertal younger girls, absolutely. We're talking about those that we often do see in sexual health clinics, and obviously we've got to take into mind about safeguarding, GILIC competence, and making sure that you're fully assessing them in those areas. But absolutely, that age shouldn't preclude the person from having emergency contraception or ongoing contraception. So absolutely assess them in the same way, make sure that you fully inform them and that you give them choice. And I would say that includes IUDs. Yeah, I think the youngest person that I've fitted an IUD is a 14-year-old. So they are able to consent, and they often have the procedure much more easily than often older people are, or those who perhaps come with other experiences. So So it's really important that you offer the same emergency contraception for the post-pubertal, that you offer them the emergency contraception coil as well. Is there any other questions there, Catherine?
I think that's the main thing for now. And I think the only thing that I would just add in, and it may just be my level of paranoia in life, but if you've got somebody who is sort of peri-pubertal, so maybe hasn't had a first period but is showing signs of puberty, I would tend to go down the route of potentially giving emergency contraception anyway.
That's a really good point. Yeah, because obviously we know that ovulation can occur even before first period. And I think the other thing which I didn't mention before is in terms of covering somebody for infections when you're fitting an IUD, the guideline for that obviously changed in the last 2 to 3 years, and we would cover with doxycycline if you are concerned about high risk of sexual infection, which obviously would be in these cases. So it's thinking about covering appropriately for sexual infections if you're doing an invasive procedure like an intrauterine device fitting.
I've got another question which is related to contraceptive. Do you want to start now, or do you want to leave questions until the end?
No, let's do it now.
So another question is saying, can you explain regarding recent use of progesterone? Is it POP only or COCP, HRT progesterone component? And what is the time interval before use can be instigated?
Yeah, really good question. So we think there's an interaction between progesterone and the receptors that work with ulipristal acetate as well. So if progesterone is being taken 5 days before, then potentially the ulipristal acetate won't work as well. And so that would be any progesterone containing method, whether that's HRT, combined oral contraception pill, the progesterone only pill, or levonorgestrel. So really good question. Yeah, and it's 5 days. So if somebody's previously had levonorgestrel, they can have another levonorgestrel. If they've had UPA, they could have another UPA. So yeah, it's a good one to ask, obviously, when you're doing your medical history, because then you'll get a much better, clearer picture of what medications they're taking. And yeah, HRT, not one I'd obviously thought of, but you're absolutely right. It's got the progesterone component, and that could impact in terms of those receptors for ulipristal acetate working more effectively. So thank you for that. Okie doke. So post-exposure prophylaxis is the second area that entity that we should be able to risk assess for at the time of an acute presentation in a sexual assault centre. So what is PEP? So Pepsi is a combination of antiretroviral medications. It's usually taken for 28 days following a high risk exposure to reduce transmission of HIV, and it does this incredibly successful. We've got quite a lot of data now around the use of PEP, and it does appear to prevent HIV transmission. It should ideally be commenced within 24 hours, but you can use it up to 72 hours. But after 72 hours, there doesn't seem to show any benefit. So don't use it beyond the 72-hour mark. What's in the Pepsi? Well, we've got 2 medications, and this there's been a very recent update to what we give out now. So we've got Truvada, which is the combination of the tenofovir and the emtricitabine, and that should be taken once a day. And then we have Acentris, which is also seen as raltegravir, and previously it used to be 600 milligrams BD, and now it's changed to 2 tablets at one go. So both of them are once a day medications, and this certainly will help in terms of compliance. So just make sure that you've got those updated medications in your cupboards if you do give it at the point of access. And of course, that is what our ideal should be, and we'll come on to that a little bit more in a minute. When we look at HIV data across the UK and in Wales, this has been a bit of a success story, really. And what we can see is that year on year, we actually have had a reduction in HIV diagnosis. in the UK in 2020, 99% of those diagnosed with HIV had also started on antiretroviral treatment, with 97% having a suppressed or undetectable viral load, which of course is where we're aiming for. And in Wales, what that meant was that of the just short of 2,500 residents who were receiving care for HIV, 96% have an undetectable viral load. And some of you may be aware of the U=U campaign that has been going on, which essentially means undetectable, means untransmissible. So if you're on medication and you're compliant with your medication at least 6 months and you have an undetectable viral load, then really there is no risk of you transmitting HIV to somebody else. So it's been a real success story when we've been thinking about HIV campaigns over the last 2 decades. And in Wales here, we've recently had published the HIV Action Plan. Leonard Morgan has done that with a task and finish group. And you may have seen some pictures recently of Mark Drayford with the CEO of the Terence Higgins Trust. So this action plan is available on the government website, and it really outlines some of those successes that we've had, particularly around PrEP, which has been available since 2017 and has probably been one of the main reasons why we've had a reduction of almost 75% in new HIV diagnoses here in Wales. More people are testing, which is good, and certainly 2022 saw the highest number of testing than we've ever seen before, and that's probably a combination of face-to-face but also online provision. And many of you will be aware that through COVID, all sexual health services really went onto online platforms, and we had the rollout of Frisky Wales over Wales so that anybody could access STI screening free of charge at any time they need, 24/7, which has really improved STI screening rates. And this action plan has 30 actions and 5 key areas around prevention, testing, clinical care, living well with HIV and tackling stigma, with the ultimate goal of having 0 transmissions by 2030. So no new diagnoses by 2030. So a huge, a great aspiration, but probably one that we actually now see as quite realistic with the way that testing, diagnosis and use of ARVs is being done in Wales. So fantastic. Coming back to thinking about, well, who is it we're going to give to PEP in our sexual assault referral centre clinics in the acute presentation, I would just refer you to the BASH guidelines. So the British Association of Sexual Health and HIV, like the faculty who work with contraception, BASH would be the go-to in terms of STI risk and management. And they've recently updated their PEP guidelines in 2021. So I'll try and highlight some of those differences as we go through. But they would advise or recommend that PEP is used where there's been significant risk of HIV exposure. So risk will depend on the type of sexual exposure, the viral load of the index case, or in this case, the assailant or perpetrator, the susceptibility of the recipient or the victim in this case, and that could be potentially because of trauma either to the vagina or the anus, and whether there's any presence of other sexual infections such as genital ulceration that could obviously cause breaks in the mucosal barrier and lead to transmission, and whether there's been multiple exposures. Data would suggest that risk of transmission in a one-off episode is actually quite low, but where there's been multiple exposures, either with multiple assailants or multiple exposures over 72 hours, then that risk is increased. And one of the main things that changed now is that we are looking at population risk of those who have a detectable viral load. This is one of the main changes in the 2021 updated guidance. Before, it was just about potential population risk. Now it's around that the source is HIV positive with a detectable viral load. And so that's what we need to think of when we're thinking about potential use of PEP-C. So the source of the risk, they still have this particular table in the updated guidelines, just to give you an idea around potential rates per 1,000 people of people with a a detectable viral load living with HIV in the UK amongst heterosexual, gay and bisexual people, and those from different cohorts and ethnicities. So worthwhile just familiarising yourself with that, particularly if you have people who are travelling in on holiday, for example, or whether coming from abroad. And risk per exposure, this has not been changed much since the 2015 guidance. And of course, this data has been extrapolated from different cohort studies and modelling studies. And essentially, the most at risk exposure is receptive anal intercourse, whether that's with ejaculation, obviously higher than without. And then we have sharing or injecting equipment, and that includes chemsex. And then we have obviously insertive anal intercourse, and that differs between those who have been circumcised and uncircumcised. So again, just worthwhile having a printout of this in your SARC clinics so that you're familiar with obviously those potential risks per exposure, so that you're thinking about whether to give out PEP. And when to consider has also changed. There's been a couple of updates to this particular table, if you're familiar with it from the 2015 guidance. PEP-C is definitely recommended where there's been receptive anal, insertive anal, or receptive vaginal sex in people where the source, so that in this case is the assailant, the perpetrator, is known to have HIV and is not on antiretrovirals, and so has a high viral load. It's considered for those who have an unknown HIV status, who where insertive anal sex has occurred, or where insertive vaginal sex has occurred in those who again have a high viral load. And the main change is the one around receptive vaginal and insertive vaginal sex where there's an unknown HIV status, and that's been changed to generally not recommended. But I think what we have to consider, obviously, in the situation, the scenarios that we're talking about, where obviously perhaps where somebody has been sexually assaulted and that episode of sex is most likely to be traumatic, then there is a potential that obviously there's been a break in mucosal barriers due to that trauma, and we would consider PEP. And it's most likely that you know, there'll be some anxiety around PEP when you're having that discussion with somebody. And so thinking about population risk after such an event, sometimes it's not as clear cut. And this is where I think if you do have any questions or queries around whether PEP should be used, then it's having those conversations with your local sexual health consultants or HIV leads who may be able to give you a bit of support and advice, because it can be a challenging conversation to have with somebody. But these would be the incidences on the right hand side where you may want to consider it, particularly in those where it's not recommended or considered, because these are higher risk potential episodes. So where another sexually transmitted infection is present, or where there is pregnancy. In pregnancy, a rise in progesterone hormones increase the virus receptors, so transmissibility is greater in pregnancy. As we've said, where there's been multiple episodes of exposure, or individuals at higher risk, such as in transgender. So be aware that these guidelines exist, that they can be very, very helpful, that I think it's worthwhile having them printed out just to review. But sometimes that question of whether to start PEP or not is not as straightforward, and it's knowing who your local person is. You can phone to sort of ask a friend. When you initiate PEP, it's really important that you document well, because it's not just around that you have prescribed it, but it's sometimes around the justification for not prescribing it. And so by working through a template of pro forma, it can just help to make sure that you document everything effectively. We're going to come on to baseline blood tests. Provide a 28-day pack of Pep C. So previously we would give out 3 days or 5-day starter packs. That's not recommended anymore, and that's come through from the recent 2021 updates from BASH. Certainly through COVID, we were giving out 28-day packs because we wanted to minimise people attending clinics. And this is a practice that is continuing to ensure and support compliance. So ensure that if you are delivering PrEP, that you are giving out the 28-day packs. And certainly locally, we are working to see if we can get that into our new Pathways run clinics as well. Make sure you've got follow-up in place, because follow-up will be required at least for the HIV repeat test 45 days after finishing PEP. So it's quite understandable that at the time of a forensic examination, everything that's just happened, that the person may not actually take on board everything that you're saying. So ensure that it's written down, and if possible, you make that appointment for their follow-up in a sexual health clinic, so that the person doesn't have to start ringing up and making those appointments themselves, because it may not happen. And it often doesn't happen. So ensure that the follow-up is sent to the sexual health clinic, that details around what's been given, emergency contraception, Pep C medication, is sent to the sexual health clinic, so to ensure that continuity of care, which is so important. Tests. These can be a little bit controversial, can't they? Because I'm very aware that in some of our sexual assault centres here in Wales, blood tests, for example, can't be done, and so it's thinking about, well, what is the best for the victim. And ideally, we don't want a victim going to an A&E at midnight on a Saturday or a Sunday and having to wait for several hours to be seen by a doctor who may not have as great an understanding around Pep C as you do, as the forensic medical examiner or as the nurse working in the sexual assault referral centre. So BASH do give some guidance around baseline 2-week, 12-week and 6-month tests. When it comes to baseline, there is still a requisite for that kidney and liver function screening, but I think if you've done a very good medical history, you'll know whether there could be any predisposing liver or kidney issues. When it comes to a pregnancy test, that is obviously important, because you need to be able to advise somebody that although Pep C can be used, it's not licensed, and sometimes we do change the dosing of medication in pregnancy. So it's generally raltegravir 400 milligrams twice a day to be used, as opposed to the full 1200. So pregnancy test obviously important, and HIV. And whether that's a blood test or whether you could use a 4th generation pocket test, that's maybe something that you can discuss with your local sexual health clinics, to ensure that obviously the person doesn't have a predisposing infection if they don't know their HIV status. There's also recommendations around hepatitis B and hepatitis C testing. But I think if you have somebody who is high risk, to take perhaps a pragmatic approach around those baseline blood tests, discuss it with your local sexual health clinics, and it may be that they're followed up in a couple of days at a sexual health clinic to get the rest of the blood tests done. So definitely a difference between sort of the gold standard and what BASH is recommending, but bear in mind that these PEP guidelines are for all presentations for PEP, whether that's occupational and other sexual exposures, as well as obviously the scenario that we're thinking about, which is following a sexual assault, and understanding what the risk is of the person in front of you for predisposing HIV, hepatitis B and C infections. Missed Pep C guidance is really important, because again, it's best to have this in written form, and the BASH do have a patient information leaflet which is recommended to be given out at the time that you're giving out Pep C, just to remind them of what is potential missed pills. So if they missed one, take it as soon as they remember. If they've missed more than one, it's take the one that is the most recent, but definitely not recommended to start doubling up or tripling up on pills to make up on ones that you might have forgotten. And if more than 48 hours has elapsed since the last dose, it's actually recommended that they discontinue taking PEP. Follow-up. I think we've mentioned most of it. The key thing is to ensure that they know when they're going to be having their repeat HIV test, and that's probably 12 weeks or 45 days after PEP has been completed. And the most effective PEP from the data appears to be where somebody has almost 24 access to help and support if they need it. Now, I'm aware that's not always available everywhere or realistic, but ensuring that somebody knows where they can ring, where that helpline number is that they can call to ask advice around potential side effects, or if they're having missed pills, or if they're having problems taking the medication, that they know where to access. And as I've said, having that follow-up with a local sexual health clinic, making sure that they have the pro forma and the paperwork, it just encourages continuity of care and completion of PEPC, which is what obviously the main driver is. Is there any questions around that, Katrin, around PEP in the?
Just a question, where's the BASH website?
Great, www.bash. Just put that in, or even just put in BASHH, and it tends to be the first hit that you come to. If you go to guidelines, which is a ribbon bar along the top, there should be one for guidelines. Go to guidelines. You can either put in PEPC or PEP, PEP, or you can go to all guidelines, drop down, and it'll be about halfway down the page. So yeah, really useful guideline. Definitely worthwhile having a little review if you haven't done that recently, because there has been some key updates since the 2015 guidance. Into the last 5 minutes, this is around screening for sexually transmitted infections, which is the final element of the ask that we have from the Faculty of Forensic and Legal Medicine when it comes to acute presentation. This is a heat table that is not even out yet. I managed to get this from my colleagues in Public Health Wales, who are putting some data together for the most recent diagnoses around STIs. So this is hot off the press. What we can see, this is between 2012 and 2021, diagnoses of chlamydia, gonorrhea and syphilis in Wales have climbed steadily. First herpes and warts has reduced, and most likely warts has been to do with the HPV vaccination that has been out for quite a number of years now. But worrying that we're getting those increase in numbers between the chlamydia, gonorrhea and the syphilis. And I'm sure we could have a whole nother lunch and learn around the reasons behind that. But important to bear in mind when we're thinking about STI screening and follow-up following sexual assault. When it comes to where those tests are being done, predominantly they're being done in our sexual health clinics in Wales and our GP practices. There has obviously been a little bit of change in terms of numbers that are now being done at our test and post site. And I think that is a good thing. It means that it's more accessible around the clock. And we certainly direct people to test and post for asymptomatic screening, or for test of cures, often for chlamydia. So it's a really accessible way of being able to get your sexual infection screening tests to your door. And prison rates, that we've only really started picking up on those since 2019, which is why there's a little bit of a gap in some of the data there. So sexually transmitted infections, I think we need to think about the consideration of when we do them. Remember that most sexual infections will have an incubation period, and that's why it's important that the victim, the person, knows where and when they need to be screened, because often, particularly for chlamydia, about 80% of people are asymptomatic. So they have absolutely no signs or symptoms of an infection, but it can have long-term morbidity and sequelae, particularly in women, if left untreated. So consider when you're testing, which is, baseline compared to, which is obviously going to be looking at any sexual exposure from 2 weeks previously and backwards, to the follow-up, which will obviously look at capturing if there's been a sexual infection that's been transmitted through that particular assault. So chlamydia and gonorrhea, the recommended test now is a nucleic acid amplification test, and the NAT can be done on either a swab or on a urine sample. In women, it's recommended that a vulvovaginal swab is done, and data suggests that it's just as good as if a person does it themselves, if a clinician does it, and that might be more acceptable for many people. And the first catch urine, obviously for males. Extragenital samples, we tend to use the swab, and that can be obviously a rectal or an oropharyngeal swab. Although sensitivities can be variable with those results, and you'll see that on the results when they come back from the labs. BASH also recommend at baseline that you could consider doing a syphilis test, a hepatitis A and B test, or a hepatitis C, which is obviously more high risk in men who have sex with men, and also those who inject drugs. So important to consider what could be the risk of sexually transmitted infections, the person in front of you, but also potentially, obviously, the assailant or the perpetrator, and thinking about the advice that you're going to give the person about when they're going to be tested for sexual infections and how they're going to be tested, whether that's going to be Frisky Wales and online, or whether that's making an appointment for them to be seen in a local sexual health clinic or with their GP.
Just a quick question, sorry.
Yes.
Helen. So it's just a quick question to say, is it generally available for single swabs for GC and chlamydia on that testing? I know it is for Cardiff, but I just wanted to double check.
Yes, yeah, absolutely. It's going to be the one swab, full vaginal swab for chlamydia and gonorrhea, and we really only do sensitivities, microscopy if there's symptoms of a vaginal discharge, for example, and then obviously that would be a face-to-face. Usually a speculum examination with an endocervical swab. Thank you. Hepatitis B vaccinations. Ideally, you would want to be able to give the first hepatitis B vaccination at the SARC centre to somebody who has been sexually assaulted, particularly, obviously, if they don't know their hepatitis B vaccination status. There are various schedules out there for Hep B, and they all have kind of their pros and cons. We tend to go for the ultra rapids, particularly in people who we think may not be able to attend in the future or may not want to come back, because that can be quickly done at 0, 1 and 3 weeks. Perhaps the disadvantage of that is that titers at that 3 week is only about 80%. Although if you give a booster at 12 months, it tends to go up to 96%. But you have to kind of weigh that against maybe the standard regime, which obviously has the best response. But obviously you're asking somebody to come at 0 at 1 month and then at 6 months. And certainly data suggests that uptake of the 6-month dose is quite poor. So it's weighing up those pros and cons. And remember, for those who are also at high risk of hepatitis A, so MSM, you can give the double injection, the one that has both hepatitis A and hepatitis B together. So just be aware of that as well. So follow up for patients in terms of STIs, really important that you signpost them appropriately to where they're going to get their testing and follow up, and make them aware there is a possibility that so many of these infections do not have signs and symptoms. And that's why it's so important that they return for their 2-week chlamydia gonorrhea test, so not less than 2 weeks, and that they return for their 12-week HIV and syphilis test as well. I've mentioned a chain of evidence there. My colleague Katrin, who's been supporting me today, is the paediatric lead for SARC in Cardiff, and is going to be doing a whole nother lunch and learn around prepubertal children, and this is where chain of evidence can be incredibly important, and of course that is something that needs to be considered. You know, it's not something that a sexual health clinic can just suddenly do. Chain of evidence, there's paperwork, there's in terms of bagging the evidence and ensuring that it can't be tampered with. It's something that you would need to discuss with a site that is used to doing it, and getting the support obviously of your colleagues in the sexual assault referral centre and potentially the police as well. So that's 45 minutes. It's probably enough for a lunch and learn, but if there's any other questions, do put them in the chat. And if you have any ideas for other lunch and learns, or there's particular area that you want in more detail, then do let us know, because we want these sessions to be helpful for you in your practice, and we're certainly open to putting on other lunch and learns that you think may be beneficial for your professional development.
I've just got a couple more questions, Helen.
Yeah.
So just a question saying about, do we always use the chain of evidence, which you've already sort of partially answered. So I'd say, yeah, for paediatrics we certainly do, but generally the young people are being seen in sites where we've got it all set up, but it does help from that respect. And then we've got another question there from Esther, just saying, have you got any specific advice how to explain to a patient how to do self-taken sample correctly? Are there any sort of leaflets or videos?
Yeah, so on the Test and Post website, there are some infographics around how to do vaginal swabs. And we do put leaflets when you go onto the Test and Post website and you get your screening kits through the post. There is a leaflet in there about how to do your test as well. So certainly if you're going to be accessing it on your own through a Test and Post website, there is information out there, and certainly if you were to go on to BASH, there's also more for healthcare professionals and clinical advice about how they should be taken. But really, I would say a vulvovaginal swab is pretty good. I usually say if you insert it about the length of your little finger inside the vagina and you rotate it, rubbing around the inside walls of the vagina for at least 20 to 30 seconds, then that should be adequate. So yeah, they're pretty good tests, the DNA PCRs.
Another question for Farah, which we could probably answer together. So saying, should we collect STI screening samples for the children, young people examined for historic child sexual abuse, especially if asymptomatic? I certainly do that as part of my routine work, as long as the child's consenting to it. And I think it just adds an extra layer of reassurance. I think a part of that is also having an understanding about whether it's a young person who whether only their sexual experience has been their abusive sexual experience, or whether they're also involved in consensual sexual activity as well, obviously depending on their age. But I think so it's sometimes worth just thinking about that as to whether it's good to be plugging in with sexual health services, thinking about their ongoing health needs, or whether you're doing it as part of more of the forensic medical examination and reassurance from a SARC point of view. So I think there's sometimes a bit of a fine line between the two.
Yeah. And I think from an adult point of view, obviously it's in terms of that person can always obviously leave the SARC clinic and do their own testing if they want to know what their sexual infection status is at that time in history, and therefore it's something outside the medical legal element of what that forensic examination is, and so it's quite important that you think about that if you are doing baseline STI testing in the SARC environment for that part of that forensic examination, because obviously that's different implications.
Got just another comment then, just saying a talk aimed at primary care would be very helpful if not already planned.
Yeah, absolutely.
And then what would you advise as a triage for a GP out of hours in case of UPSI? Apart from emergency contraceptive, will you advise A&E or sexual health clinic self-referral or GP next day?
For which particular, I mean, if you're seeing them and you have the key thing is obviously going to be emergency contraception and PEP. And then I think in terms of the STI follow-up, that person can either go to a sexual health clinic or they can access Frisky Wales online at the 2 weeks, because that's the soonest that you're going to be able to get a positive swab from an event. So I think the key thing is imparting that information to them if it's out of hours, giving them emergency contraception, signposting them to have their coil fitted if that's their choice, and that you give them PEP, because obviously that's the other time limiting factor. It's best started within 24 hours.
And I suppose the other thing is, I suppose if you've seen that situation with respect to a sexual assault, then it would be discussing whether that person would like, you know, to make a referral to police, but also maybe signposting, if they didn't want police involvement, signposting to their local SARC with respect to other support around advocacy or counselling and the other services that might be appropriate.
Yeah, yeah.
I think that's all the questions, Helen.
Oh, thanks, Katrin. Thanks for your help. Thank you, everybody. Thanks for the suggestion around the primary care lunch and learn that we can look at. We can absolutely put that to Jo, who you met at the very start, and we can think about when we can schedule that in. Thank you for this lunchtime, and enjoy the rest of your day.